इसमें से देखिए इसमें ज़्यादा क्लियर होगा। एक तो कल है 10 मिनट्स में है likely rounds है that is not sure lightning rounds I don't know because you can please see I'm so sorry about that because yeah I think the Sami might be knowing about it she's the one okay let me just see where she is I think she might be in another room but they will let you know any of the people on the registration list from the women's side they will let you know नंबर को शुरू कर रहे हैं उधर डॉक्टर अतर Yeah, that's what I'm trying. Yeah, that's what I'm trying. साइड के पहले स्पीकर हैं, so that's why.
Assalamu alaikum wa rahmatullahi wa barakatuhu. Bismillahir Rahmanir Rahim. Welcome everyone to the MSLM 25 conference.
Yes.
We're just going to get started with our next session. This is one of a few parallel sessions that's occurring at this time. Our parallel session is entitled The Future of Healthcare. And I'm honored to moderate this session along with my co-moderator, Dr. Asma Awan Saiba. We have exciting speakers planned for this session. In fact, I would request our speakers on the men's side to please join me at the front. This is Dr. Hafeez Rehman Sahib and Dr. Musa Sami Sahib. If you could please come to the front desk here. And we'll get started with our first speaker, which is Dr. Hafeez Rehman Sahib. Dr. Hafeez Rehman is a board-certified internal medicine physician with over 25 years of experience in private practice. His practice focuses on evidence-based clinical management of diabetes and obesity-related metabolic disorders. Dr. Rehman is a fellow of the American College of Physicians and a member of the Ahmadiyya Muslim Medical Association, USA. He is affiliated with St. Mary's Hospital in Amsterdam, New York, and serves as a clinical faculty member for the nurse practitioner program at Russell Sage College in Albany, New York. His talk today is on Revolutionizing Health, the latest insights on metabolic syndrome guidelines. I turn it over to Dr. Rehman Sahib.
Do we use this or are we using this mic? Ideally, yeah, I think it's this working. Okay. Who's going to run my slides? Do we know?
We have the AV.
Okay. So if you could put up the first slide, then I will keep guiding you with those. All right. So, A'udhu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. Well, first of all, Dr. Malik, thank you for the kind introduction. We are in an unprecedented era of medicine. We have done a lot of advancement in the healthcare, especially improving the health of mankind. The gym membership is all-time high. Everybody is concerned about the weight and the health implications. And yet, despite all that, we see that the epidemic of obesity is all-time high. And I will explain that this is not the obvious obesity that we see, but rather obesity that's internal as well, that causes far more damage to the human body that we can ever imagine. Next slide, please. So my first slide is a message to my all audience today. And that message is that our people, our population in United States here, especially, worldwide to lesser degree, but here, is being attacked practically by two large industries. See that? Food industry on one side, and on the other side, pharmaceutical industry, which claims that food industry creates problems for the mankind and we create drugs. Of course, the drugs that are very expensive, they create that. And we are right in the center there, right in the center. Physicians trying to help, or healthcare providers trying to help our patients. And that is a very difficult problem. Now, my talk today is about metabolic syndrome, and I have written them all in one succession. Why? Because they're all linked. Metabolic syndrome is in reality, insulin resistance, and that in reality comes from obesity, whether that is internal or whether that is external and internal together. And I will explain that further once we go up in the slide. Next slide, please. So it will be astonishing for you to know that 80% of the US population, that is a data about 10 years old, it is now somewhere 93% of the US population is metabolically unhealthy. Meaning that leaves only 7% roughly that is healthy. 30% of the total US population is obese. However, let's remember that 20% of this obese population is metabolically healthy. They look obese, but they are metabolically healthy, and we call them MHO, metabolically healthy obese. And yet, 40% of the normal weight patients that are walking today in the United States are metabolically unhealthy. They look thin, they look fit, and we call them TOFI, thin from outside and fat inside. And ironically, the population of healthy weight population far exceeds that of obese, and yet the healthy-looking people continue to blame the obese people for the problems that healthcare industry suffers today. Next slide. Oh, I can play? This side is going forward? Okay. So, metabolic syndrome, which is a general term, is the cause of 75% of the healthcare problems today. 75. It actually starts with insulin resistance, meaning insulin is a hormone that our pancreas produces in response to the food, certain foods. And when it comes out, its job in the bloodstream is to drop the glucose, get the glucose absorbed by the cells so that the glucose could be utilized for the energy purposes. And when that does not happen, that is called, in general term, insulin resistance. So insulin resistance suffering population is in reality TOFI plus MUO. So thin from outside, fat inside, and metabolically unhealthy obese people, that is the combination of these two that makes up that 93% of the US population. So once that we understand, we go forward now. Now, how do we diagnose this? How do we know that we have that condition? Everybody asks that question. And there is a poor man's test that can be done technically without even going to the physician's office. And that is doing a waist circumference, not where the belt goes, but right above the navel, approximately. And if you are measuring over 35 inches for women, and if you are measuring over 40 inches for male, you have at least a threat or one component of the metabolic syndrome, and that is sign of internal obesity, the obesity around the organs, which is far more dangerous because that produces inflammatory cytokines throughout the body, and that causes further worsening of the insulin resistance. And we have an old formula that still insurance companies want us to continue to observe, which is, of course, outdated, doesn't make any sense, and that is body mass index over 30. That will make Arnold Schwarzenegger, who was one of those bodybuilders, an obese person when everybody knew he had a lot of muscle bulk, and he always was over 30. So I, in my clinical practice, do not follow this, but I have to put it because insurance companies want us to put it. And we are doing nowadays another measurement which directly indicates insulin resistance, and that is body fat index, BFI, which should be 25% of your body weight or under. If you are doing over that, there is a problem, and that's based on that we calculate total body fat calories. As you know, 1 gram of fat carries 9 and the calories, and 1 unit of the glucose has 4 and proteins have 4. So that's where we stand. So when I say the fat, we calculate the fat, it is not an inert organ, not an inert area. It is for the energy usage for the future that nature has created for us to utilize at the time when the body needs it. But the problem in America and worldwide nowadays is that we never give a chance for that fat to burn, which creates out of the regular food that we consume every day. These are some telltale signs of the metabolic syndrome commonly seen in people and gets ignored. They go to physician, they get treated for onychomycosis or the tinea pedis. Nobody pays attention to do an A1C and check on the, or put a CGM to see what's glucose doing. The other is very common also skin tags. People ignore it. Some people go to their doctors and they want them removed, but hardly it gets noticed that this might be a sign of excess skin growth under the influence of insulin resistance. And acanthosis nigricans, an old known term that we have seen throughout our medical career, dark skin, thick skin, particularly around the neck and the armpits and other skin folds. And back of the tongue gets thickened, and that is macroglossia. That is one of the contributing factors for the sleep apnea, which can further worsen the cardiovascular disease and insulin resistance. So I'm not going to read all of them, but these are all the effects of metabolic syndrome. Look at this. 75% of healthcare problems today attributed to this. If we could fix it, we could work, we could help a lot of humanity, not only in this country, but throughout the world. Why? Because this kind of processed food that is mainly responsible for this problem is now seen in all other countries. This is the effect of America and the capitalism that has taken all these processed foods to worldwide, and you see in Arab countries everywhere these fast food chains that are open, creating havoc to the human health, and nobody's paying attention to it. Now, because of the time constraints, I'm going to continue to come towards wrapping this talk. Of course, this is a very vast subject, a subject that should nearly take 12 hours in my opinion. It is between 12 to 15 minutes, cannot be resolved, but we have to find solutions. And that is what has been my struggle for last 5 to 6 years, that I said, I have more diabetic patients than an endocrinologist in my town, almost 4,000 to 5,000 patients, and all of them were getting big, getting obese, not getting better, cardiovascular health catastrophes all the time seeing, and helplessly sitting writing those prescriptions, not knowing what to do, because that's what the guidelines were showing. And something had to occur, and then search into this field led me to believe there is a solution. It is a hard solution, but it has to be tackled. And the nature has already told us that solution. The problem is we are unwilling to take heed to that and continue to see the consequences of this. And you know why? Because majority of these processed foods have an addiction element, because they deliberately put fructose and sugar, and that compound is as addictive as cocaine and heroin. The only thing is that the sugar and the alcohol is socially acceptable, but the sugar, in the case of a sugar, because of its socially acceptable, nobody says that this is an addictive behavior. People say, oh, I have a sweet tooth. Well, when they do, then that's a real problem. Now, I want to take you to this simple picture that I once saw in a journal, and I liked it so much because it gives you a whole story of my talk today. Whole story. This is what food industry has done to us to morally equalize these two things that you see on your screen today. Eat a donut. Hey, calories are calories, no matter where they come from. That's the concept. The problem is human body is not a calorimeter. Human body works with hormones in response to what we consume. And those hormones decide where that food eventually goes, whether that goes for ATP synthesis, which it should be on the majority of the time, and not for fat deposits. That's where they have been successful in convincing the population that all calories are created equal when they are not. And that's what we have to convey to our patients today. You have an apple that came from a tree. You can make an apple pie. That's not a real food. And a change of a mind is needed to curb this situation, or else we will continue to go into this trouble. Now, our cells are the eventual recipients of what we consume. They are the mini of us, I should say, mini me. And every cell, their needs can be met with these food items that I have written there. They are all needed for our food. And guess what? Tell me how many processed foods have these. They have been stripped because that's the only way they can increase the shelf life. Strip the fiber, strip good proteins. They cannot keep them on, the real foods. And the animosity towards healthy food, since Ansel Keys' study came out, where he sold basically his soul and told us that we should go on high carb and low fat diet. And ever since that, from the 80s, we have seen the explosion of the healthcare, dollars being spent on cardiovascular disease, heart attacks, those type of things. Hey, we have to go back to the basics. And the basics, by the way, was taught 1400 years ago by the Holy Prophet ﷺ, by the direct guidance of God. But yet, we find that despite having the knowledge, we are not able to capture the essence of the message, unfortunately. And it's high time that we do, and convince the world that listens to us that, look, the solution was provided so many years ago. One of them is fasting. Allah in Holy Quran said 1400 years ago, fasting is good for you if you only knew. By the way, 12 hours of a fasting, where you, in this particular case that I'm talking about, intermittent fasting, where water is allowed, 12 hours of your precious time, your body is certainly consuming without a difficulty all the glucose that you have consumed. Okay, all of it. And then after 12-hour mark, the fat burning actually starts. That is why fasting is the key and the central element to reversing the metabolic syndrome. Second, giving our bodies enough rest to avoid the attack of cortisol, at least 6 to 7 hours of good sleep. Third, doing musculoskeletal exercises to trigger those muscles that have been squeezed out of life by the high fat percentage, so that they could start burning glucose efficiently, and we could see them in real time on the CGM, by the way. We could see it. Nowadays, we have the technology that could let us know what's happening. If your muscles are up and running, you'll see how good they respond. And going back to high and good protein, good fats, and carbohydrates that are only present naturally in fruits and vegetables will 90% of the time eliminate this problem. In other case, we would have to utilize GLP drugs, which would have been the next talk, by the way, where we could see how GLPs can help us reverse the metabolic disorder and get us towards a better state of health. Jazakallah for your attention.
Jazakallah, Dr. Ahmad Sahab. Please join us here. We'll take questions at the end of the session for all of our speakers, and I'll turn it over to Dr. Asma Awan Saiba to introduce our next speaker.
Ji, Assalamu alaikum warahmatullahi wabarakatuh. Dr. Athar Malik and Jazakallah, Dr. Hafeez Rehman, for a very insightful presentation that you have given. Just going to the metabolic syndrome that you have described, that reminded me of the Holy Quran verse, chapter 7:32. And eat and drink and do not exceed the bounds. وَكُلُوا وَاشْرَبُوا وَلَا تُسْرِفُوا. And pertaining to the psychosocial effects of the metabolic syndrome and the triggering of the body and the mind exercises that you have mentioned, that is going to connect to a recent study in Sweden that has been done in older people, saying that 10 out of 15 elderly people have developed their brain exercises and decline in their demented attitudes after going through those exercises. That is going to connect to our next speaker. She's going to unfold all these possibilities, that how the human brain works and how the cognition decline in the older age helps in the atypical situation. So our next speaker is Dr. Ayesha Ahmad. She's a board-certified internist and geriatrician, serving as a faculty at Penn State Health. She's the program director for Geriatrics Fellowship at Penn State Health and also serves as the vice chair for diversity for her department. Her areas of interest are end of life, dementia, and transitions of care. She also serves as local legislator for Harrisburg, Pennsylvania chapter. I invite Dr. Ayesha Ahmad to give her insightful thoughts on this topic.
Okay. Assalamu alaikum. Can everyone hear me okay? All right, Jazakallah. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم أشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبده ورسوله. I wish to convey my sincere Jazakallah to all the program committee for giving me this opportunity. So my talk today is about the clinical spectrum of atypical dementia syndromes. Did it go forward? Yes. And in full disclosure, I will not be touching on the subject of how to prevent dementia. So in some ways, it doesn't tie into the previous talk. So even though dementia is not named in the Quran as a disease as such, but these verses really highlight the cognitive and the functional decline that happens with old age. So the first verse is from Surah Al-Nahl, the bee. And Allah creates you, then He causes you to die, and then there are some among you who are driven to the worst part of life, with the result that they know nothing after having had knowledge. Surely Allah is all-knowing, powerful. And then the next verse is from Surah Al-Rum, or the Romans, or the Byzantines. And the verse says, "It is Allah who created you in a state of weakness, and after weakness gave strength, and then after strength caused weakness and old age. He creates what He pleases. He is the all-knowing, the all-powerful." So my objectives are to just broadly define dementia and its subtypes, talk a little bit about the prevalence of these subtypes, and give a very, very broad overview of the clinical presentation. I will not discuss neuroimaging, biomarkers, and treatment options in the interest of time. Sorry, did I skip a slide? Sorry. Wait. Yes. So, thank you. Before we actually touch the content, I included a slide about language. And I think language really matters when we talk about older adults. So I wanted to create the space to discuss that. Avoid saying elderly or seniors. The correct terminology is actually older adults. And in order to give dignity to both our patients and their care partners, it's better to use a person living with dementia rather than, "Oh, my patient is demented or senile." A lot of our nursing affiliates may use the terminology, oh, they are a total feed or they are a Hoyer lift. So it's much better to define them by how much help they need. For example, they need help with eating or they need a Hoyer lift to get out of bed. We sometimes talk about patients with dementia with behaviors. It's better to call it symptoms of distress or unmet needs. And then it's always better to call the caretaker as the care partner, because I think the caretaker is definitely a word that does not include some of the things that the care partner is doing. So broadly, dementia is a collection of symptoms, cognitive, functional, and behavioral, that are often caused by a specific disease. So it's an umbrella term. And most of us, if we, let's say, pull 10 people that are over 90 off the street or off a cohort, the most likely dementia that they are going to have, if they have a cognitive decline, is Alzheimer's. So you'll be statistically correct if you make that diagnosis in 60 to 70% of our patients. So again, I'll reiterate that it's an umbrella term, and the biggest subtype is Alzheimer's. But today we'll be talking about some of the other subtypes, which are vascular, Lewy body, frontotemporal, mixed, and then there is a small, tiny amount of what's called rapidly progressive dementing illnesses. Okay, I seem to have gone. All right. So the first subtype I'd like to talk about is Lewy body dementia. Some people put it on the umbrella of dementia of Lewy body type. And there's an emerging body of evidence that now basically divides dementia into tau proteinopathy and alpha-synucleinopathy. And even for those of us who are not that interested in how these pathologies happen in the brain, suffice it to say that the synucleinopathies are a bunch of neurodegenerative disorders which are caused by the accumulation of a certain protein called alpha-synuclein in both neuronal and non-neuronal cells. So these are some of the core clinical features of Lewy body dementia, and on the other side of the slide are the supportive clinical features. The core clinical features, and I think this may be important for even some of us who may be care partners or may be experiencing a loved one in our families that have dementia, I think it's important to be cognizant of these core features. So the first is cognition tends to fluctuate along with the level of alertness and attention, almost on a daily basis. Patients with Lewy body dementia often have recurrent, pervasive, detailed, and very vivid visual hallucinations. They often have a REM sleep behavior disorder, which may actually precede the cognitive decline by years. So it's important to sometimes interview the spouse or the partner about REM sleep disorders like vivid dreams, calling or crying or yelling in their sleep. And then lastly, patients with Lewy body dementia often have motor symptoms of Parkinson's, which are an asymmetrical tremor, rigidity, and bradykinesis, which is defined as a very almost a slowness in initiating movements. Some of the supportive clinical features are exquisite sensitivity to antipsychotics. So our pharmacy community will recognize that these patients, if you give them an antipsychotic, they are going to react by becoming extremely rigid, far more altered, and you could actually increase their hospital stay by days. And Lewy body dementia often manifests with severe autonomic dysfunction. So patients can experience falls, drops in their blood pressure, excessive sleep, loss of smell, systemized delusions, apathy, anxiety, and depression. And there is good data to indicate that anxiety and depression can precede Lewy body and often the alpha-synucleinopathies by decades. So I forgot to mention that Lewy body dementia is the third most common of dementia. So approximately 10 to 12% of all patients diagnosed with dementia will have Lewy body. Next is vascular dementia, or for those who trained very early on or who are more seasoned geriatricians or neurologists are used to seeing multi-infarct dementia in place of vascular dementia. So vascular dementia also has 4 phenotypes. One is the subcortical ischemic vascular dementia, which basically exhibits just by a slow processing speed, slow speech, slow executive abilities, overall just slowing in every domain. Then we have the most commonly known post-stroke dementia, where someone actually has a stroke and develops a cognitive decline either immediately or within 6 months. And obviously this happens when the stroke happens to include the angular gyrus, thalamus, basal forebrain, basal ganglia, or posterior cerebral artery. The third phenotype is multi-infarct dementia, where you have multiple large cortical infarcts. And because you actually have a large infarct that can easily be seen on an MRI, you usually have motor signs as well. So you would have apraxia, which is difficulty doing motor movements, aphasia, which is loss of language, visual field deficits, or symptoms of either paralysis or neglect. And then the last kind is mixed dementia, which has pathologies of both Alzheimer's and vascular dementia. And this is not surprising because age is the hardest risk factor for Alzheimer's. And as we all know, with age comes hypertension, diabetes, and a risk of strokes. So mixed dementia is actually quite common. The third atypical dementia is frontotemporal lobe dementia. The big thing about this dementia versus the others that I've talked about is this is a disease of younger people. So this often happens in people under 60. It often masquerades as a psychiatric illness. So a lot of these patients will end up seeing the psychiatrists or their primary care physician first because of changes in their personality and behaviors. Head trauma and thyroid disease have been linked with the development of FTD, and there is a particular protein degeneration that happens with frontotemporal dementia, including TDP43. So there are 3 variants of frontal lobe dementia. One is the behavioral variant, where patients present with altered behavior, personality changes, disinhibition, loss of emotional reactivity, and something I find super helpful is apathy. They become, very unmotivated to do the things that they normally would do. They have impaired abstract thinking, and their executive function worsens over time. The second variant is the semantic variant, where you have quite a significant difficulty with word finding or understanding the meaning of words, impaired comprehension, and extreme amount of difficulty in recognizing unfamiliar objects or face. And then the last kind is, some of our neurologists may be familiar with this, is the primary progressive aphasia. These patients present with halted speech and just jumbled words, and they don't make a lot of sense when they talk. They have difficulty in understanding complex sentences and naming objects. So the two key features in frontal lobe dementia is that their speech is affected. Either it's fluent and nonsensical, or it's halting and still nonsensical. And then there are a lot of personality changes. And then there is this small cluster of rapidly progressive dementing illnesses like Creutzfeldt-Jakob disease, which is a prion disease caused by a tiny particle that is even smaller than a virus. Vasculitis, which is basically inflammation of the blood vessels. Progressive multifocal leukoencephalopathy. Wernicke's, which is associated with high alcohol consumption and thiamine depletion. And then there are some unusual variants like mitochondrial disease. So here are some take-home points. I know some of you may not be entertaining careers in neurology or geriatrics, but I think it's hopefully useful to know for everyone who cares for older adults. 80% of all dementia is Alzheimer's in type. Vascular is the second most common. Lewy body or DLB is the third most common, highlighted by visual hallucinations. There are a handful of Lewy body dementia associations across the nation. Reversible causes are less than 10%, such as vitamin depletion, thyroid disease, etc. Rapidly progressive dementing illnesses are rare, and if you happen to find a patient who is literally declining in a matter of weeks and months, then look for referral centers, and the best ones around us are Penn, UCSF, and Mayo. So I'll end my talk here, and hopefully we'll have questions at the end. Jazakallah.
Jazakallah, Dr. Ahmad. And with that, we go to on the men's side to Dr. Athar Malik. Please, Dr. Athar Malik, go ahead, and then we'll take the questions at the end. Jazakallah.
Jazakallah. We'll turn to our final speaker of the session. We're fortunate to have Dr. Musa Sami Saab visiting us from UK. Dr. Sami has over 15 years of clinical, academic, and leadership experience. He is a leading consultant psychiatrist committed to helping patients navigate complex mental health challenges with compassion and clarity. He has his MBBS from Queen Mary University and a PhD from King's College London. Dr. Sami has worked across the NHS, private sector, academic institutions, rehabilitation units, and digital telepsychiatry. His expertise spans the full spectrum of adult mental health, including anxiety, depression, bipolar, psychosis, PTSD, substance abuse, and dual diagnoses, with a focus on practical, science-based solutions that fit real lives. Dr. Sami has contributed to more than 30 publications, delivered talks across the globe, and developed research that explores the link between cannabis use, psychosis, and brain function. He's presented this work at world-renowned conferences, and we're honored for him to be speaking to us today on his topic, uncovering neurobiological differences in early psychosis with and without cannabis use, findings from the EFCIP study. Dr. Sami?
Jazakallah. A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Okay, sure. That introduction was too effusive. I didn't recognize that person. I put my CV through ChatGPT. It came out with something like this. So apologies for that. Okay. So my name is Dr. Musa Sami. I'm a consultant psychiatrist. I'm going to present the results of my PhD. So the challenge I have today is that it took me 2 years to get the funding, 3 years to do the study. I have to present this in 10 minutes, so please bear with me, but I'll go quickly, right? So let's start with what the Quran says about psychosis. So, as the last speaker mentioned, there are two very good verses on actually dementia and frailty in the Quran. And as a psychiatrist, I know this very well. The Quran talks about all types of mental health conditions. It also talks about what I would say psychosis, schizophrenia, or generally serious mental illness. And they're very profound verses. I'm not going to go into the depth of all of them, right? But these are verses that I'm sure you all know. They're from Surah Al-Qalam, where the Holy Prophet ﷺ is told that you are not, by the grace of your Lord, afflicted with insanity, which means the boon of your Lord. And if we think about this, I think it's important for all of us to think, those of us especially who don't have serious mental illnesses, this is only a blessing from Allah Ta'ala. And it's something when I see patients who are severely unwell, I'm always thinking about, why am I in this chair and the patient in that chair? It's something that we should all reflect on. And so let's just start off with psychosis, or what we know about psychosis. Psychosis is actually a very unspecific term. Most people, when we talk about psychosis, we think about basically what are called positive symptoms of psychosis. So it's one of three symptoms. You're either having hallucinations, delusions, or thought disorder with specific type of confusion. If you have one of those three, you're psychotic, right? Or you are experiencing psychosis. But whether that's a psychotic symptom, whether it's a psychotic episode, whether it's a psychotic disorder, there's a lot more to tease out from there. There's several domains which are associated with these conditions. I've told you about positive symptoms, there's negative symptoms, mood symptoms, cognitive symptoms, and obviously there's overlap in all of these conditions. In psychiatry, we have something called the nosological problem, which is that we can't essentially define our conditions properly. And everything that we do is based upon our clinical assessment. We have no scans and no blood tests which tell us about our condition. That doesn't mean that it's not a scientific specialty. It just means that it's not a technologically advanced specialty at the moment. And that gives us rise to some very interesting scientific conversations. But what this actually means is that we have several different conditions which are overlap. We can change diagnoses. People drift from one to another. Schizophrenia is the most common psychotic disorder that people will have heard of. And there's certain known risk factors for having psychosis. So being of a minority status, having had past life trauma, particularly in childhood, life stresses, genetics, and drugs such as cannabis and amphetamines play a role. And psychosis, the other reason why it's important to know about this and to think about it, is tends to respond actually quite well to simple medications that we've developed since the 1950s, dopamine 2 receptor blockade. And if we don't identify this and people remain psychotic, then risks can escalate to themselves or others. And so we need to know about this condition. So cannabis is, the formal name is Cannabis sativa. It's been known for thousands of years. We use it for hemp rope as well. But we've been smoking it as a species for a long time. It's basically the flowers or the buds of the flower, which are psychoactive. These were isolated in, I think, the 1960s to two main molecules. One is called THC, the other is CBD. And THC particularly is a psychotomimetic, i.e. it stimulates psychosis-type symptoms. And the reason this is important is that half of my patients with psychosis smoke cannabis. Now, I just want to think biologically about what's going on. THC actually is a CB1 receptor agonist. CB1 receptor is the most widely spread GE protein coupled receptor in the brain. It's extremely widely spread. You can see from these scans about its distribution. It's all over the gray matter. And it doesn't actually regulate a final neurotransmitter like dopamine, right? It actually is presynaptic, so it regulates GABA and glutamate presynaptically. And because it does that, that's why every different person that you speak to will tell you different effects that they get from smoking cannabis or weed. I've done this a lot. There's maybe 50 or 60 different symptoms which are associated with cannabis intoxication. And this is ubiquitous, right? And so what we're doing when we're smoking weed is we are messing up a very tightly and finely regulated system. And this is where this presentation will get to. Now, as I say, 40 or 50% of my patients with psychosis smoke cannabis. And, okay, there's something I'm sure you've all heard of called the self-medication hypothesis. Self-medication hypothesis is the idea that people, if there's an association between a drug and a condition, people might be using the drug in order to help regulate their condition. As a psychiatrist, I'm not going to get into all the debates about this. There's some merit in that, but I've never ever known a person with psychosis who smokes cannabis and gets better. Like, I've never ever known a person who is depressed and drinks alcohol who gets better. It doesn't happen, right? Drugs worsen mental health conditions almost invariably. I think, and you know, the data shows this. So if you use cannabis, your illness onset will be earlier, your relapse will be worse, you'll stay longer in hospital, you'll have more admissions, we'll need more medication. There's something really interesting in the literature that we've known for a long time, that you actually have fewer signs of biological impairment in the cannabis users. So memory performance is better, hippocampal volume is better, there's fewer what they call neurological soft signs. So essentially, I was looking at this to see if there are differences between the patients with psychosis, early psychosis, who use cannabis and who don't use cannabis. So then, of course, you need to collect data from 4 groups. So patients with early psychosis first 5 years, who use cannabis, patients who don't use cannabis, controls who don't use cannabis, and controls who use cannabis. And so essentially I subjected them to a battery of tests, you know, every which way I could measure them. There was some sense to this, which I'm not going, you know, I didn't just choose them at random. I won't go into every detail of why I chose them, but I was looking at structural MRI, MR spectroscopy, functional MRI, eye movements, lots of questionnaires about their mental health status, about their drug use, and collecting lots of data. And so I'm not going to go through all of this slide in detail. The main thing that's important is when you do any of these studies, what you want to see is, are your groups different in age and demographics? Do you need to vary for any confounders? And basically, my cannabis-using patients and non-cannabis using patients were basically the same in terms of diagnosis, in terms of medication, in terms of how long they'd spent in hospital. I mean, there were some things which were expected. Cannabis users, obviously, they drink more and they smoke more than the non-cannabis using compares. Patients in general have a lower IQ than controls. These are things you expect, but we can co-vary for them. It's not major, right? So now the thing is that what I found is over a range of different features, different tests, you know, and different ways of getting at the brain, there were differences between the cannabis-using patients and the non-cannabis-using patients. And these are all related to different aspects of neurobiology. So in terms of, we looked at subcortical shape analysis. So we found that there was increased enlargements of the putamen and the thalamus, which are structures involved in compulsivity in the cannabis users. We found differences in terms of a hyperconnective state in functional connectivity of some important networks, the dorsal attention network and the dorsal attention network connecting to the visual networks. Of particular interest to me is that there was a link between gray matter volume, given that, as I've showed you, CB1 receptor density is very high in gray matter, and the glutamate levels we could measure in the associative striatum. So in cannabis users, but that wasn't seen in non-cannabis users. So that might mean that there are some kind of projections, you know, maybe from the amygdala, hippocampus, projected to the associative striatum, which regulate in cannabis users glutamate in a way that doesn't seem to work in non-cannabis users. So there might be some different neurobiology going on here. And then there's a very old very old measure of schizophrenia called smooth pursuit eye movements. There's literature that goes back to 1908, which shows that these are impaired in patients with schizophrenia. And what we found is that the patients with who used cannabis didn't show that same deficit. And what that might mean is that cannabis might tip you over the edge, even if you don't have that same biological predisposition to psychosis, schizophrenia. That is that it might be a component in, you might not get the psychosis if you hadn't smoked that weed. So these were important differences. And I mean, I'm not going to go through all of this. I've discussed some of this as well. But overall, there's very good evidence suggesting that there are different pathways, both to and maintaining psychosis for the cannabis and non-cannabis using patients, if we look widely at brain function. And I think the most important thing that I want to get across here is that the brain is a very tightly regulated system. Our cognition, our language, our facilities, we take these all for granted, but it's very tightly regulated. If we undertake, drugs, cannabis, amphetamines, alcohol, we're essentially disrupting that tight balance. Your brain is your most precious asset. Please look after it. Okay, thank you.
Is this micro? Oh, Jazakallah. Jazakallah, Dr. Sami, and Jazakallah to all of our speakers. We maybe can take just a few minutes for some questions. If we have some questions, please come up to the microphone to ask the question. Are there some questions on the ladies' side that we might start with? Otherwise, we do have questions on the men's side. Please. And if the questioners could just introduce themselves as well. Jazakallah.
Assalamu alaikum. This is Zed Safullah. My question is for Dr. Ayesha Ahmed. So I understand this could, be out of the scope of your talk, but in the ICU, we liberally use antipsychotics for treating agitation from all etiologies. But I was wondering, in your opinion, is there evidence to support a certain kind of, phenotype of dementia responding in a different way to depending what kind of antipsychotic you give?
Assalamu alaikum. So if I understand the question correctly, what is the safest antipsychotic to use in ICU delirium?
Or is there, say, vascular dementia responds better to Seroquel versus some other type responding better to Zyprexa or something like that?
I think the golden rule is that if there is a hint of PD, Lewy body, in their history or on their exam at admission, avoid the traditional and the second generation, use Seroquel. I could talk about Precedex too, but that will take too long. So I would say Seroquel is generally safer unless there's orthostasis and low blood pressure. If there is even a hint of alpha-synucleinopathies that I earlier talked about. Otherwise, all antipsychotics have been studied ad nauseum, probably Haldol more than anything else. The golden rule is to use lower doses than your typical antipsychotic doses in robust young people, and watch for QT prolongation. So does that answer your question?
Thank you. Jazakallah.
Jazakallah. Are there any questions on the ladies' side?
This is Naila Ijaz, cardiology fellow. I had one question for Dr. Rehman and another one for Dr. Sami. For Dr. Rehman, my question is, that insulin resistance sometimes, causes increased hunger, and so many people I know, can't even fast during Ramadan because of that. They just cannot tolerate hunger. I don't know if it's like hypoglycemia symptoms or such. And so is there anything outside of GLP-1 agonists for such patients, and that could, what would you advise them? My other question for Dr. Sami is that, so you had mentioned, smoking cannabis and its association with psychosis. Now, like topical THC is advertised a lot for aches and pains and other things. Is the same association, do you know of the same association with topical, am I saying it right? Is it a topical cannabis use, basically?
Okay, Dr. Saiba, can you please ask your question again? I did not understand the first portion of it, that you were talking about intermittent fasting or fasting?
So I was saying that in many people with metabolic syndrome and insulin resistance, they feel like they cannot fast because of the increased hunger that they feel as a result of insulin resistance as well. Mm-hmm. And so is there anything you can advise them outside of GLP-1 agonists?
Yes, so very excellent question. Actually, there wasn't any time to go on that when I was speaking. Actually, there are, as you know, a couple of different ideas about the intermittent fasting. There is time restricted, it's the other name, is caloric fasting, and then there is a metabolic fasting. So metabolic fasting is an interesting concept in which you could consume certain food items that do not trigger the insulin release. And I have wore a CGM, I actually have a CGM right now on me, only to study this aspect, and it is strikingly very interesting that I'm finding out for last 1 week, and this is the third time I've wore a CGM, and bone broth, for example, chicken broth,
CGM is
continuous glucose monitor. There are different brands. So as a result, those people that struggle with the fasting element, that their water intake or green tea is not curbing the appetite and they're challenged by it, they could use bone broth, they could use chicken broth, they could use beef broth. The insulin release from pancreatic source will be extremely limited as a result of those, because it does not trigger those. And as a result, you could easily offset that. And I have done that to myself to show that to patients, and I have put it on the videos too. And it's all over the internet too. Many people do that kind of fast. And that, as a result, obviously it's not an Islamic fast, it's an intermittent fast. So you could easily do that. And the real benefits of the fasting actually do start after 12 hours. That's again to reemphasize. All the way to 18, and sometimes once a month or twice a month, a 24-hour fast will trigger autophagy, which is very great for the body to fight against cancer, to fight against cardiovascular disease, reestablishment of new proteins in the body, better skin, all those things. Hanging skin solution that people are worried about after losing weight, best to trigger autophagy. I hope that answers your question.
Assalamu alaikum, Dr. Saiba. Thank you very much for your question. I just wanted to, maybe you could just educate me a little bit. You're talking about topical THC preparations being advertised. Because I'm from the UK, I'm not from here. Are you saying that these are available over the counter, or are they?
Yes, I think they can be ordered online. They're not regulated, and people are getting them in the US. I'm not sure about Europe, but they're like oils, I think.
Yeah, and so you're not saying they're FDA approved for anything? Exactly. Yeah, okay. Look, okay, so if we just think about kind of bioavailability, it doesn't matter how it is, how you receive the drug, right? So, I mean, it matters the dose, and it matters how it's absorbed. For example, one of the problems with oral cannabis was that you can't titrate your dose, right? If you have cannabis cookies, for example, or sorry, if one has cannabis cookies, they don't know how much they're actually taking, and it might become available some hours later. Whereas if one is smoking a joint, or then they know if they're getting a high dose, right? So whereas it was thought that edibles were safer than smoking, that's not necessarily the case. So again, with topical THC, it depends, what the dose is and how it's being absorbed. But, it has to get absorbed into the bloodstream, has to get to the brain, has to cross the blood-brain barrier, and it will still have exactly the same effect. The second thing I would just make is, I was in this area of research for a long period of time. I was in the kind of scientific prestigious units who were talking about it. I went to the conferences talking about it. There was a lot of cannabis hype going on, right? Just like Dr. Saab, my friend, has talked about, the industries of the pharmaceutical industries and the food industry. And I could see the cannabis industry. It was developing, it's been developing since 2015. It's still going strong. The evidence hasn't borne out the kind of wacky claims that were being made, but they still managed to get that funding into universities, into programs, stories out into the press. That changed perceptions in general society. I'm sure it did here, it definitely did in Europe. And it became a bit of a self-fulfilling prophecy. And I'm very skeptical about some of the claims which are made. I need to see the proper scientific evidence, and I don't even trust the experts to tell me which ways things are going after having been in this for a long time. I want to see the papers and the data for myself. I hope that makes sense.
Jazakallah from the ladies' side. It's time for lunch, and all the speakers, they have their expertise. You can connect to them off the line, and inshallah ta'ala, you will get more insight into it. So off to the lunch in the foyer on the men's side and on the ladies' side as well. Jazakallah. Assalamu alaikum.
Jazakallah. We'll also conclude on the men's side. I'd like to thank all of our speakers and my co-moderator. These are very hot topics with the emergence of metabolic syndrome, dementia, and increasing use of cannabis and related products. And so please do continue the conversation after the session with our speakers. Jazakallah. And we'll have lunch next, followed by Jummah at 1:30
Assalamu
p.m.
alaikum. Lunch will be served just around the corner here, to your left. Not to the right, but to your left. It's right there. And the restrooms are there.
Jazakallah. Assalamu alaikum.
Namaz room is also right there. Everything is in this area.